and welcome to this series, a new series of conversations focused on the National Preventive Radiology Initiative of the Indian Radiological and Imaging Association. This program is a pioneering program in India, and it aims to bring the best of clinical care and research, combining latest science and personal experience for clinical care of patients in different disciplines of medical care in India. We have two panelists with us today, Dr. Rijo Mathew Choorakuttil, who is the National Coordinator of the Preventive Radiology Program of IRIA, who is a radiologist, a consultant radiologist with his own center, and is also the founder and a lead member of the Samrakshan program of the Indian Radiological and Imaging Association that focused on reducing perinatal mortality in India. Welcome, Dr. Rijo Mathew Choorakuttil. The other panelist with us is Dr. Manoj KS, who is a consultant radiologist with KIMS at Thiruvananthapuram, and also is a consultant radiologist with the Pioneer Metro Scans at Thiruvananthapuram, and has got both clinical and research experience with liver conditions, and has worked in different research studies that have looked at imaging modalities and the comparison of different imaging modalities with respect to the liver. So, welcome Dr. Manoj to this particular conversation.
Thank you. Thanks.
To start the conversation, I would like to ask Dr. Rijo to give a brief introduction about the Preventive Radiology Initiative of the IRIA, what's its aims, its scopes, and its broad activities that are visualized under that, and to discuss a bit about a pioneering concept, the Preventive Radiology OP, that he is planning to introduce and implement as part of this program.
Thank you, Dr. Praveen. Preventive Radiology OP is a concept that we want to promote as part of the Preventive Radiology Initiative of Indian Radiological and Imaging Association. Diagnostic radiology and interventional radiology are well-known entities within radiology, but one particular aspect of diagnostic radiology, before the patient becomes symptomatic, the preventive radiology, in the larger realm of preventive medicine, preventive radiology has got a role to play. That is something that we have realized, and we thought we will explore it for early detection of lifestyle diseases, cancers, malignancies of cancers, and even some of the infections or endogen diseases like chronic kidney disease or chronic liver disease with the help of imaging biomarkers. So most of the modalities that we use in radiology and imaging, like the ultrasound, CT scan, MRI, etc., are capable of picking up, having imaging biomarkers to look into some of these early biomarkers to look for early identification of chronic endogen diseases like chronic kidney disease, chronic liver disease, and even early detection of cancers. And one of the focus that we have given is for the non-alcoholic fatty liver disease and the non-alcoholic steatohepatitis, otherwise called as NASH. That because fatty liver is something the radiologists have been seeing ever since we have been using ultrasound. And of late, for the last 20 years or more, we've been seeing a larger number of patients with fatty liver. And initially, it was ignored by the clinicians, but the relevance of fatty liver is becoming more and more important, because fatty livers, significant percent of them can go into fibrosis and then into cirrhosis and may require a liver transplant. And some of them, once they go into the cirrhosis, can develop hepatocellular carcinoma. So this is the significance of early detection of fatty liver, and to reverse it at a stage when it is possible to reverse it with the help of dietary modifications, exercise, and medical interventions, is something that we have to do at this point of time, rather than waiting for another 20 or 25 years to the fatty liver to really show its this thing, with a lot of cirrhosis cases, lot of liver transplantation being required and the complications to be managed by the medical healthcare. healthcare personnel at that point of time. So we thought this is the right time that we have to skill enhance 20,000 radiologists in the Indian Radiological and Imaging Association to work on this particular branch of preventive radiology, were imaging biomarkers with multiple multiple modalities of imaging, radiology and imaging. After using them, we will be able to stratify the risk of the community or risk of the and can specifically work on a high risk group to reduce their complications or prolong their uh, life expectancy or and improve their quality of life. So this is the broader perspective of preventive radiology program of IRIA, and as part of this concept, we want to promote the preventive radiology OPD, because most of the time radiologists are people who are not running an OPD. We are not competing with the other clinical specialties to run an OPD. But for preventive radiology, this is a must. This is a necessity that we have forced to do with, because the patient here is an asymptomatic person. The symptomatic patients go to a physician, surgeon, or most of the time into the OPD of some of the clinicians. But for a preventive radiology, this thing, the patient is asymptomatic. But if they've got a family history, if they've got a risk factors, they are the people who has to be screened, undergo these imaging modalities to look for the imaging biomarkers and to stratify them as high risk or low risk groups for further interventions with the help of other clinical team. So this is the concept of preventive radiology, and welcome to the first preventive radiology OPD that we are doing it here in the virtual mode. And I am extremely happy to have Dr. Praveen Nirmalan and Dr. Manoj KS here with me in this OPD.
So, Dr. Manoj, why is non-alcoholic fatty liver disease and NASH important? Why is that a priority? And what do we mean when we say those terms, when we say those clinical terms, as a patient or as a layperson? What do those terms actually mean?
Very good evening. Thank you for inviting me to this program, Dr. Rijo and Dr. Praveen. Uh, Actually, the problem of fatty liver, as Dr. Rijo has said, it's maybe one of the biggest epidemics that we, especially in India or especially in Kerala, we may be facing. In fact, when we thought about all the deaths in COVID season, in fact, people became aware what is an epidemic and what devastation it can have make. Now, the fact is that this is a silent epidemic, and when we think about this COVID having attacked sort of 90% of the population, this particular disease is already has made its mark on, as some of the studies are showing, 50% of the population. That means it is a very, very huge number that is going to evolve. Unlike, I mean, when we compare the COVID, okay, COVID will evolve within a week, and the problem will start seeing in second week. This will come in a decade, and the problem will come in the second decade. So this long period of time gives us both a problem as well as an opportunity. So that is where I think the our initiative will make its mark, because we have this time period before us, and when we think about all the demography, all these factors put together, of course we are at the right time, and the technology itself has sort of matured in the last one decade, so that radiologists is at a level where we can introduce this into the mainstream. In fact, it might have been difficult even 2 3 years ago, as I have myself experienced many of these technologies, and I think that is very important. Now, coming to the point of NAFLD and NASH, that terms, I think we have different definitions given by our different uh, groups, and that definitions make use of the pathology as the benchmark. The pathology is the benchmark to state whether it is mere fatty liver or it is NASH. But as I was telling, the imaging technology is now at a tipping point where we as radiologists or using our technology will be able to also tell, okay, this is NASH rather than NAFL. So that is where I think our importance or the concept, everything comes out. Okay, as a preventive radiology, OPD or anything that kind of a initiative will work, because we are now able to tell the clinician, okay, see, this is not something you can ignore. I think that brings the importance of all the scheme.
Okay. So NAFLD has got a period where it is not symptomatic, it's asymptomatic, and then it can progress over a period of, it's a progressive condition that can progress over a period of time to a point where patients exhibit symptoms, and that can be within a decade or can be a little longer as well, and it can then progress to a condition where there is advanced liver disease, where you might have to end up doing a liver transplant. We also have imaging modalities now that are better defined, that have got more improved technology that allow for a better differentiation of the condition through the imaging modality, as well as early identification. So in both terms, in terms of the ability to identify early, as well as in the ability to differentiate between the conditions and tell that, well, this particular subgroup needs an intensive or a more intense monitoring and intervention. This particular subgroup can be just observed over a period of time with certain changes in lifestyle and other risk factor changes. What are the imaging modalities that are commonly used to identify NAFLD or NASH? And how do these patients come in for imaging? Are they referred from the clinical setting? Do they come in at an earlier stage? Do they come in at a later stage? Or is it that you identify most of these cases in patients who are coming in for an imaging for some other diagnosis? Anyone?
Yeah.
Anyone?
I think, as I've already mentioned, radiologists have been seeing in fatty liver, has been reporting fatty liver as part in most of the USG ultrasound abdomen studies. And we have graded it as grade 1, grade 2, and grade 3 at that point of time. It has been there for last 20 years or 25 years or more. But then now we have understood the significance of a non-alcoholic fatty steatosis or just a fatty liver, or whether it's a fatty liver with inflammation, which is called as the non-alcoholic steatohepatitis, or a fatty liver with progressing fibrosis and become with cold echo pattern leading into a cirrhosis. So what happens is fatty liver is so common now that because of our dietary habits, because of our lack of physical exercise, because of maybe increased drug intakes, hepatotoxic drug intakes in various systems of medicine. So there are a number of reasons for increased incidence, and diabetes is one of the very common conditions that can cause fat deposition within the liver. So there are a lot of conditions that predisposes now for a fatty liver, and fatty liver is something that we see very commonly as part of a routine ultrasound abdomen study. Now we have to categorize from this fatty liver which are the patients who are likely to go in for a likely to have a fatty inflammation that is called as a steatohepatitis, or likely to have a progressive stage of fibrosis. So enzyme studies like liver function tests, SGOT, SGPT, enzyme studies may help you to detect a group of patients with fatty liver having a inflammation, but the progression into fibrosis of different stages is something that is still not being investigated. That is why we have to integrate liver elastography into the protocols of these patients and categorize them as those people who have got a increased fibrosis and a compensated advanced liver disease, which those people and those people who are at the borderline risk can be advised for lifestyle modifications and medical interventions where a reversibility of fatty liver and fibrosis is possible at that point of time. So we have got ultrasound elastography in terms of there are two different modalities there in ultrasound itself. One is called as it came earlier, which was called as fibroscan, that is the transient vibration control transient elastography. That is by using a equipment point, this thing where you are blindly applying that vibration control transient elastography and trying to get the uh, yeah, trying to get the stiffness of the underlying organ. But there can be problems if there is ascites, because we are not particularly seeing that tissue there. It's a blind procedure, and but since it came early and one of the earliest modalities to detect fibrosis, that is still now very popular. The other one is in elastography is using ultrasound is shear wave elastography. To 2D shear wave elastography, that can be a point shear wave elastography or a 2D shear wave elastography, where you can see the 2D image of the liver and can get the elastography values or the liver stiffness value. And what we mean by elastography is the stiffness of the liver. The liver is normally a very soft structure. When there is more fat deposited there, and when there is more inflammation due to fat, and when there is more fibrosis, the due to the fatty inflammation, the stiffness of the liver increases. So that is being recorded with the help of liver elastography. The 2D shear wave elastography is a much more advanced technology that is now slowly stabilizing, and with quality parameters like motion stability index and reliability index, which will help us to understand whether this particular section is a good section with proper breath holding and proper section of that reliability of that section is good enough. So that is the second technology. In ultrasound, we have got this fibroscan or vibration control transient elastography and 2D shear wave elastography. Another technology that is being made, another imaging modality that is being used is MR elastography with magnetic resonance elastography. That again can give you the fat quantification as well as the fibrosis scores. The liver stiffness can again be measured with the help of MR elastography. And the final thing, most of the gold standard or the thing that we usually want to compare is a liver biopsy. But that's not a radiological modality. That is a pathological procedure, which is an invasive procedure. And we cannot subject every patient to a liver biopsy, which is an invasive procedure. It has got its own complications. So that is why a non-invasive imaging modality is being increasingly used, not only for the detection and grading of fat, but also for the assessment of liver fibrosis, liver stiffness, or the inflammation of fat, inflammation and the fibrosis this fat is produced in the liver, to assess that. So ultrasound elastography, 2D shear wave elastography, and MR elastography are two radiological imaging modalities that are increasingly being used and very commonly now being available, and which we intend to utilize for the IRIA Preventive Radiology Initiative for in non-alcoholic fatty liver disease and NASH. And we are doing multicentric studies with at least a minimum of 10 centers all over India, where we are comparing the diagnostic effectiveness of fibroscan or the vibration control transient elastography with 2D shear wave elastography, with MR elastography, and biopsy in possible cases. So this is how we have designed that particular study. I've already explained about the modalities that are being used. The importance is liver elastography has to be integrated Just the fatty liver diagnosis or grading is not enough, because you just don't know which category of them are going in for a progression into fibrosis and into cirrhosis, and maybe at a stage where they can be the fibrosis can be reversed. So this is the concept behind.
So what we are looking what we are looking at is the elasticity of the liver to a certain extent, and we are saying that when there is a fat deposition in the liver, which is a naturally elastic organ, tends to lose its elasticity, and as fibrosis develops, it becomes more and more stiff, and so measuring the stiffness of the liver helps to give a sort of quantification of the condition of the liver. The other part that comes in is that we have a fat deposition in the liver, which is leading to all of this, and hence, is it possible to quantify the amount of fat that is there in the liver? Is that a measure that can be used to stage the disease? That is one question. The second question is, when there are different modalities, naturally a natural question is, why is one model? How does one modality perform against the other modality? So does magnetic resonance elastography, MR elastography, give advantages over a shear wave elastography or a VCT, a vibration controlled transient elastography? So two questions, Dr. Manoj.
Yeah, as Dr. Rijo has clarified, we are having the problem of fat, which is the predominant, what is the fatty liver problem, which will have added problem of having a inflammation component of inflammation plus necrosis. That is what we call as a steatohepatitis. So when it comes to the steatohepatitis or NASH, we have fat plus inflammation plus necrosis. That is a pathological diagnosis, and this can progress into fibrosis, and this fibrosis in turn progresses into cirrhosis. So that is the progression of this problem. So as we said, liver is a very pliable, soft tissue, and when there is only fat that is accumulating within it, the stiffness or that pliability, that essentially will not change much. So that is exactly the point that helps us when we are using shear wave or when we are using MR elastography to diagnose whether this liver is normal or not. That is the cutoff point, that the first point that we are going to make. As we know, we have now some cutoff values that have been developed over time with the various researchers, and I mean, there has been a lot of research actually, and the comparison studies, and so our ultrasound society and the American radiologies has come out with the consensus statements regarding what should be our cutoff values with respect to a normal liver and an abnormal liver. So we have, I think, in shear wave, we have got a value of 5 kilopascals as the cutoff value for a normal liver, and in MR elastography, that is 3 kilopascals. So now, as radiologists, we are sort of having some sort of a biomarker or cutoff value to define what is normal liver. So once we say, okay, this person is having a normal liver, there is so much of uh, impetus to the problem that we are facing. Okay, this is we can sort of try them to normals and abnormals, and then we get to the next level. Okay, this is abnormal. Then what is the grade or the degree of abnormality. So that is where the technology further helps us to grade uh, this fatty liver problem into the stage of inflammation or whether there's a stage of fibrosis. And then fibrosis itself, we have the, we are always comparing it to the pathology. So pathologically we have 1, 2, 3, and 4 grades, and that has been correlated with the elastography values. So there we can put some numbers to the patients or the livers, and this value, whether that holds true, that is actually the concern. So far we were all, all these technologies, when we are utilizing that, whether this value I'm just now doing on liver and I'm getting this value, whether this will be it will hold true when we are doing it in next month or after 1 year. So that is where the I think there is some degree of uncertainty in that values when we are looking into the final terms. We are seeking to make more precise categorizations, and that's where we have to do more research. I think that is exactly what we are at, and we plan to do. What should be our cutoff values when we say, okay, this is grade 1, this is grade 2, or this patient is going for fibrosis, this patient is not going for fibrosis. All these parameters, if we can make out, that will be the next level of imaging or making a more definite opinion regarding these patients.
Yes. I think, Praveen, I just want to add on to what Manoj just said. There is definitely, because this, for any technology, I was just, any technology, the technology from the research and development to clinical practice, it usually takes 17 years. That is one very interesting study by Norris et al. That has come out in 2011. I hope you know that study. Yeah. And what I realized is, especially as I was in 2003, 2005, we were talking about this cardiac CT calcium scoring, and it took nearly another 17 years for the medical community to accept it as a part of a intermediate risk scoring system, because I am one person who was introduced that in and was talking about it and had a lot of resistance from the cardiologists in the initial phase of it. But now the cardiologists are asking, we have accepted it. In 2018, the American College of Cardiology has accepted it as a essential screening tool for in the coronary, in the evaluation of atherosclerotic coronary vascular disease. So it takes a pretty long time for once the modality is introduced, because there is a certain amount of learning curve or the uniforms or standardizations that is happening. Here the problem with elastography started with two or three things, in fact. One, as I said, between different modalities. So unfortunately, radiologists who are practicing all the three modalities, like Manoj is practicing ultrasound, MR, CT, all the modalities is practicing. But a large number of radiologists are practicing either ultrasound or CT or MR. So what happens is, it's very there is a kind of claim between two different modalities saying that ours is best, so other is bad. So it is not the in this when we initiated this preventive radiology program, I just wanted to focus on the disease. Basically, there is a problem that we have called, that is called as a non-alcoholic fatty liver disease, and we have to stratify the risk with different modalities and get some uniform standardization. Some modalities will be more sensitive, more specific. Definitely, that is how it works. But that doesn't mean that the other modalities other modalities are bad. Even a fibroscan, which is versus 2D shear wave, so far the papers that have come out from the literature, especially from the Western literature, says for a 2D shear wave has got a higher sensitivity and specificity. But fibroscan is something that is early introduced early and is commonly being used by the gastroenterologist, and that is being promoted by them. Then it is widely available also. So it is something. It doesn't mean that fibroscan is absolutely wrong or something like that. It is also a modality that has got a reasonable good sensitivity and specificity. Maybe 2D shear wave has got a slightly higher sensitivity and specificity. MR elastography may be having a much more higher sensitivity and specificity, but biopsy may be still the gold standard that we're taking, but which being an invasive procedure, we cannot go for it for all cases. So we have to see all these things in the perspective of the disease and the need for a risk stratification of the community, and rather than getting biased in the by the professionals, by the different by the different disciplines of medicine, gastroenterologists versus radiologists on fibroscan versus 2D shear wave, or between amongst the radiologists itself, between the different modalities, ultrasound elastography versus MR elastography, or between the radiologists or the professionals working on, between the different vendors itself, saying that my elastography machine is better, your elastography machine is. So all these things we need to have a uniform approach. The common thing that all of us can look into is, we are approaching a patient with we know that patient has got a fatty liver. Does that fatty liver is alarming and is in a increasing stage of fibrosis where an intervention, medical intervention or a lifestyle modification can reverse it? Or has it already gone in for an advanced compensatory liver disease where the management and the complication, and again the further progression of all these things can be reduced if we know that already it's the values of more than 13 kilopascals or more than 11. So as Manoj already mentioned in 2D shear wave, now the stiffness measurement, there seems to be a consensus now less than 5 is considered as normal. 5 to 7 and or 5 to 9 has to be considered with the help of enzymes and other clinical conditions. But between 9 and 11, we have to be very cautious that those are the cases that are going in for a compensated, and more than 11 or more than 13 are definitely going in for a cirrhotic, this thing where the chances of developing a portal hypertension, other complications are on the cards. So it has to be, my suggestion is, there has been a phase in the development of technology which is inevitable, which is bound to happen, because research and development only can happen, especially in scientific principles. This is the way it happens. And but or an important point that I want to highlight here, especially as part of the preventive radiology studies, most of the time for the standardization or the cutoff values, we were depending on data from Western literature, studies that has been conducted elsewhere, not in India. So we are making an attempt to get data from the Indian population, Asian Indian populations, on the various values using fibroscan, 2D shear wave elastography, and MR elastography, and biopsy in possible cases, to get a uniform get a data that can help us what is the normal cutoff, because normal cutoff in Western population may not be the normal cutoff for Asian population. That has been Indian population especially. That has been proved by the diabetes study, Mohan diabetes, this thing, especially in BMI. BMI that most of us are calculating as 25 as the cutoff value is no more applicable for Indians. It is 23.1. So a BMI of 23.1 is in the normal or a safer range, more than 23. So 23, because if it is 25 to 24, we got a tendency to say that, okay, my BMI is good. No, you may be in the borderline for developing some risk factors like all these things associated with obesity or overweight. So the cutoff values for Indians may be different, and that is something that we are currently evaluating, and that is one where I am extremely thankful to Mindray for having collaborated with IRIA for a multicentric study to collect the Indian data. That is where they put in their collaborative effort with IRIA to collect the Indian data in a multicentric study, especially for a comparison of diagnostic effectiveness of 2D shear wave using their zone sonography technology, and compare it with the MR elastography and other modalities. So there are problems, but this is one phase where we have to come into some kind of a uniformity with two focus. One, we have to focus on the disease and the prevalence of that disease and the epidemic that is unfolding, and that is the severity of thing that will be coming in the future. We have to understand it, and risk stratification with imaging biomarkers, especially with liver elastography, by whichever modality we use it. Whichever modality you got an access, you can do that and follow it up and stratify that risk. But then again, the second point is collection of Indian data from the Indian population, which is a highlight of this study. So I just want to highlight these 2 points. I do perfectly agree with what Manoj said. There has been a phase of confusions, especially with cutoff value standardization, and the every cutoff value that you are currently using are are from the literatures that have come from the West, not from the Indian studies.
I kept myself mute. Well, adding on to that, there are two things to consider based on what both of you just said. One is that different technologies exist, and each technology has got its own advantage and disadvantage. And there may be a comparative advantage when you compare it with another technology. Now, the important thing is not to get yourself drowned in that comparative advantages and then try to say that this is better than that, and if you do that, it's not good, and if you do only this, it's good. For the patient, the key point is not whether you did an MRE or you did a shear wave elastograph. For patient, the key thing is what's the status of my liver and what do I need to do next with it. And as long as you are able to give that particular information to the patient and guide them along the proper way, most of them don't care whether you have done an SWE or given a report on an MRE. Well, they will care if you have done a liver biopsy because that's painful and that's invasive. But otherwise, for them, the key point is, can this be managed? Can my condition be managed? Can it be accurately diagnosed? Which brings us to the next point, and it's a point across all technologies, across all diagnostic tests, that the given range for a particular condition is not something that is set in stone. It's a range. And it's not set in stone in the sense that beyond that range, the upper limit of the range, there can still be people who have the disease or don't have the disease. The lower limit of the range, there can still be people who have the disease or don't have the disease. The range is what works for most people with that disease. And usually that's said to be 95% of the people. And that's why we pick that range. And that range can again vary depending on the machine that's being used, depending on the skill set of the operator that is using the machine. And if it's a biochemical test, depending on the reagents also, the quality of the reagents that are being used and whether they are close to expiration date and all those things. So they are variable factors. Now, if you bring this back to the Preventive Radiology OP and the Preventive Radiology Initiative, we have three important components. We have a component of being able to diagnose with improved technology. We have a component of now having a set of ranges that give us a better input as to the condition of the liver. We also have a state where there are people who are asymptomatic but have a fatty liver, and there are people who are symptomatic. Now, symptomatic people have gone to a medical doctor, they have been referred. So let's say that group is relatively well taken care of. The focus of the Preventive Radiology OP is to also get the asymptomatic people into the mix. Which brings us to the point that, well, then, how do we know whom should we bring into the mix? Are there certain risk factors that can tell us that, well, if you have these risk factors, we would recommend that even if you don't feel anything, even if you feel you're perfectly healthy and well, and you don't have any symptoms, it's probably better that you go and get yourself screened with any imaging modality, with any radiologist. Open.
Yeah, actually, as we said that this range of values, in fact, that our new consensus statement from the radiology group has thought out something called as a rule of five, where, as Dr. Rijo said, we have this range of values in shear wave elastography from 5 to 7, 7 to 9, 9 to 11, 11 to 13, and above 13. So that is some sort of a consensus now we are having. And that gives us sort of a range within which to put patients. And if one patient is moving from one range to another, that brings us the importance of the condition that particular patient is facing, or the effectiveness of the treatment that or the interventions that has been employed. So that brings us sort of, more of a feel good factor, or actually it's more scientific, but still we have some numbers and we have some ranges to think about and put categorize the patients, and have uh, the problems specifically addressed to such group. Okay, if one patient is coming within that 7 to 9 range, okay, what are the things that now we are going to do about him, and what are the advices, or what are the precautions, or whatever. So that will be also, I think that should be also part of our learning processes, or part of our programs, because that uh, brings the crux of the issue, that whether we are solving the issue or not. After some doing these things for some years, we will know that, okay, somebody who was in stage 1, or somebody who has a value from 7 to 9 in 2022, whether he is still there at the same value in 2025, that that will be the most important aspect of the entire program that we are going to conduct, because we want to keep them at that same level, or even to make them better. We want to get that liver go to the normal, and not go anything further. So I think we will get more data, or more insight into the problem faced by each of these category of patients after this a well-conducted study will actually throw up so many of the data as well as the insights, so that we will be able to make more precise movements regarding how this OP will be progressing, how this entire preventive radiology concept will be developing, and in fact making a mark on all these people. Because we are not thinking about small groups, we are actually thinking about crores of people. I mean, it is it's a very huge number, and the huge numbers is, as we know, if somebody is progressing from that F1 to F3. Oh, that is, I mean, it is a terrible state, and we can see, okay, in 5 years, you should not allow something like millions of people to progress in such a manner. But, and for that, each of the risk factors, each of the problems that should be addressed, and how that should be tackled, and how that can be rectified, all these things, I think all the important questions we should be able to address at the end of the studies, or at the end of a program. I mean, after it is around for 1 year or 2 years, we should be able to address such problems. Only then we can have more people believe in in the entire concept itself. We should be having numbers to show them. In fact, why I am saying is that I have been doing this Shiva for past 3 years, or maybe 4 years. Actually, we started in 2018, and initially we were seeing all these people having this Shiva and going away, but now I am seeing many people coming back, and I am having a follow of what is happening. So I can see many people who have followed the strictly the diet, or the exercise, or the doctor's instructions. They are having very stable patterns, and even improved significantly. In fact, I have got a cohort of patients who had even come back to normal after what is called as our grade 3 fatigue. See, this is something actually I mean, I was also surprised to see, because I never believed that a grade 3 fatty liver will become normal. But that is actually happening because people are becoming aware, people are following, I mean, at least some people are following very strictly the regimens, and very much concerned. They are very regularly coming back. So that also gives us responsibility, because we should not be very loose in defining them into categories. We should have our parameters very well defined. We should have our instruments, we should have our technology, we should have our methods. All these things very well defined, and the procedure should be done under controlled conditions, so that what we tell this patient this year will hold true next year also, or year after that, and that will give credibility to the entire exercise of radiology program. The radiologist emerges as sort of a, I mean, a beacon, or I mean, in the entire fraternity, because I have seen that the other concerned physicians or the specialists are not able to do this. I mean, we know the fibroscan, I mean, all these things have been going on for years, but what we are able to see with our imaging, with our advanced technologies, the physicians, I mean, the clinicians, they are not able to visualize. We are able to visualize as well as measure, and that brings the importance of radiology, because we are in a position to document exactly what is happening to a liver, what is the pathophysiological mechanisms happening within a liver for a particular patient, and then document it, measure it, have a value, and then when we follow it up, okay, this is what is the change that has happened in a particular time period. That brings us entire thing. I mean, nobody else can do this. Only radiologists can do this. So that I think this the entire fraternity will understand, and will follow these leads, and we will have a very good teams who are able to implement the program in specific directions, and have the documentations, and that will benefit the entire population. That's where we will be progressing. And one thing I want to say is that these two technologies, this MR and the ultrasound, both depends on the measurement factor of what is the liver stiffness. So as we know, the ultrasound technology is far cheaper, and it will be available on a larger scale, and it's also easier to practice. It is easier to uh, have the patient, I mean, undergo the test, all these things. So it will be on a wider scale, and MR elastography being a more sort of having a more complexity, or it is more costlier, where MR should be applied, and what are the directions to the clinicians as well as the patients to undergo MR examination for, because we don't want to unnecessarily impose all the economic cost on all the people who are concerned about it. So I think as a group, we can bring out directions in that also. I mean, what are the steps that should be taken when we are dealing with this group of patients, and where exactly these technologies will enable to for the clinicians or the other uh, health care providers to make decisions, because decision making becomes very important at many points. Whether this patient should be put on a very strict diet, very strict controls, and I mean, should have more frequent follow, all these things. That I think we will be able to do this when we have a more precise definitions or more elegant or more defined manner of putting together all these things together. I mean, it should not be a very loose pattern of okay, you do the elastography or you do this thing, but we should have more
It has to be
precise
multi-parametric.
parameters to be followed up. And in fact, as we know, all the radiology, other investigation, I mean, in other areas also, we are now talking about multi-parametric uh, methodologies. I think this in liver, fatty liver problem and all, now the latest talks, I mean, in RSNA or everybody is talking about the multi-parametric
Yeah.
liver fibrosis assessment. That gives us another dimension, in fact. I mean, not just putting a one value or one perspective into the entire problem, but thinking as a problem in its different dimensions and also tackling it in a multi-dimensional, multi-parametric way. That will also use us better way of dealing all the different, I mean, complex
Yeah.
factors put together.
Yeah, I think Manoj has rightly brought out a few aspects which I just wanted to discuss. One, Manoj is, from his experience, he has said if we diagnose a fatty liver, even if it is a grade 3 fatty liver or a fibrosis at a borderline stage of less than 11 or this thing, there are every possibility that that can be reversed by dietary modifications, by lifestyle changes, with the introduction of regular exercise, or the or the factors like a drug-induced causes can be eliminated, or there is a window of opportunity for the patient to reverse the process or halt the progress of towards fibrosis or further deterioration of non-alcohol fatty inflammation. So that is one important thing that we have very important when we introduce this as a screening test. Any screening test for risk stratification, if it the one of the primary characteristics is any intervention that should be effective for a reversibility or can cause a Praveen, that is one of the important criteria for. So that is why this particular study becomes important. And the question that Praveen has asked here on the how do you choose the patients in a radiology OPD, the preventive radiology OPD, because symptomatic patients already will reach a physician or a surgeon or a clinician for and must have undergone the workup, and with the help of biochemical tests, the laboratory tests, or even imaging. But there is a segment of people who are at risk for developing NAFLD, NASH, fibrosis, and cirrhosis. So those are the patients who have got diabetes. Diabetes is a condition. Those patients with diabetes, those patients who have got metabolic syndrome, those patients who have got hypertension, those patients who have got history of ischemic heart disease, patients who are hypothyroid, and those patients who have got sleep apnea. Then, so as part of our study, we have prepared a protocol. Praveen is the chief research mentor for our research studies, and the comorbidities, whether it is there or not, is something that we are trying to analyze. And some of the core, if there is a PCOS in a female, that is a predisposing. She may be having a PCOS, but she might not have checked her liver. Whether she may be having an AFLD. Then dyslipidemias. Then daytime drowsiness, that may be due to sleep apnea, which is again associated comorbidity with the fatty liver. So, and again, the personal risk behaviors, that somebody who is taking alcohol more than 30 ml on a regular basis, how frequently they are taking, or tobacco use, or the use of junk foods, especially, and then the exercise activity, how much of physical exercise that they're doing. If you're having a very sedentary lifestyle, most of the time you're sitting, there is most of the time we found amongst doctors also, amongst most of us, we have seen fatty liver. So we should not take that as granted that nothing is going to happen. We are also progressing into some stage of cirrhosis. So there needs to be a screening for people who are having all these comorbidities I have mentioned. And then, as Manoj rightly said, liver elastography is one parameter that can increase the is an imaging biomarker that can increase the risk stratification to certain groups where the reversibility is more, because fatty liver right now hasn't got much of a quantification apart from the subjective assessment of a grade 1, grade 2. Though there are some attenuation values or liver hepatorenal index, all those are the things are coming up, but still the progression into fibrosis with the help of liver elastography, and there are stages at which it can be reversed also. So, and again, the third point that Manoj has brought in, it has to be a multi-parametric assessment with the help of biochemical markers, imaging biomarkers, and even the clinical parameters. I think there is a scope, even I can see here, with a scoring system integrating all these multiple parameters, which is yet to be developed with the help of course, the clinical parameters, the clinical parameters and the risk factors, then the biochemical parameters, and then the imaging biomarkers, with maybe multiple imaging modalities being brought in, where MR elastography may be used in a certain category where we have got a where we have got an ambiguity in interpreting the 2D shear wave elastography value, whether it has gone in for a compensated advanced liver disease. MR elastography can add more parameters into that, and that is how we can evolve. So, an imaging algorithm using multi-parametric multi-parametric methodology is something that can evolve out of these studies that we are currently doing.
So there are a few important things. One is that the progression of the disease must be measured, and we are using imaging technologies to measure the progress. And we have to keep that in the context or within the background context of the existing risk factors that are associated, may or may not predispose to fatty liver, but are associated with the fatty liver in that particular person, and the control of those risk factors and how do they play out in the progression of the fatty liver status. So if it's a diabetes, and if it's a diabetes mellitus, and it's a poorly controlled diabetes mellitus as opposed to a well-controlled diabetes mellitus, how does it progress, even though they are both at the same starting point, and what do we use? And we also have to, again, Dr. Manoj brought this up, that we also have to consider the cost implications for the patient in terms of the cost of the ultrasound, in terms of the cost of the magnetic resonance elastography. We also have to consider the technical complexity of the procedures involved. We have to consider the availability of the modality that is possible. And as Dr. Rijo brought in, a multi-parametric approach where we then say that, well, if you have this and this, it's probably better to go in for this additional modality to check and confirm what state it is in, and then to figure out what modality do we use to then follow up progression in that particular person. So there is a whole set of algorithms that can build in. There are clinical scores that are there based on the demographics, based on the clinical factors, based on the clinical risk factors, scores that are there that give a preliminary risk for an AFLD. There are scores that then integrated biochemical markers with that to form a clinical score. We have the imaging markers slowly getting integrated. We have the opportunity now to look and check, see whether how does SWE work, how does MRE work, how does VCTE work, and how do we integrate that with all this clinical information. Now, this is a unique program for those of you who are listening in. This is a national program that is rolling out with its launch possibly in early June 2022, a preventive radiology program under the Indian Radiological and Imaging Association, aiming to cover the whole of India in phases. Now, the importance or the uniqueness or a unique aspect of this particular program is that it is linking clinical science with research simultaneously. So it's not just saying that we are going to apply all of this and this is the program. It's saying that we are going to apply all of this. This is where we are getting our clinical information right now from. And then we are going to evaluate it, and we are going to see how it works or holds good, or what must be changed for an Indian population. And it will work in phases where we first look at the prevalence, we look at the risk factors, we look at the diagnostic effectiveness comparing different modalities, and building towards longitudinal follow-up studies. So we have information on how each segment of or each grade progresses, and what are the factors that stop progression, help it to improve, or accelerate progression. So we have risk factors, clinical risk factors, we have demographic factors, we have biochemical measures involved in it. We have a whole set of imaging parameters with the liver stiffness values, with the attenuation values, hepatorenal index, the speed of sound, proton density, fat fraction measurements, cap values for the VCT, and also the liver biopsy. The one aspect that we are keeping a bit lower down on the hierarchy is the liver biopsy. Even though that histopathology is considered as the gold standard, a pragmatic reality is that histopathology is for the very advanced cases and where you really need that background support to confirm your diagnosis. And with better imaging technologies and coming in, the scope of liver biopsy, considering it's a painful, invasive process, which is not something that anyone who undergoes it thinks back with great pleasure. So it's a painful process. So we're keeping that as only where it is clinically indicated and where there's a real clinical benefit that comes from that particular procedure. But where it's done, we are going to compare all of this with that. So it's been a good discussion. We have looked at several aspects of the imaging of non-alcoholic fatty liver disease. We have looked at several aspects of the preventive radiology program. We have looked at several aspects of how the preventive radiology OP will roll out. And I'd like to thank Dr. Manoj for bringing in his experience and wisdom and sharing that freely with us and with the viewers so that all of us benefit from that. And it's experience that has come from actual work done on the field and through research studies. And it's very appreciable that he is willing to share all of that with us. The last word, of course, will be with Dr. Rijo Mathew Choorakuttil. I think I got that right. That's a joke we both will understand. I had to tell it. Anyway, who has conceived and is implementing the preventive radiology program. So, Dr. Rijo, over to you.
Thank you, Dr. Praveen, for this wonderful discussion. I think Manoj's experience in doing 2D shave elastography as well as MR elastography, and also, as I understand, Manoj has done a few studies comparing them with the biopsies too. And being in Trivandrum, it is a place from where this particular study that is that shocked all of us, saying that 49.8% of adult population has got some manifestation, some findings of a fatty liver that has come from Trivandrum, and then it was realized that this is a emerging issue that is there in all of Kerala, and now we realize that is there in south, west, and most of the urban places. In different stages of epidemiological transition in our country, we have got this problem of NAFLD, coronary vascular disease, and all, which we need to address. So I've got this. We have already discussed about the multicentric research studies, the protocols that we have developed, and we will be sharing them with. I should thank those who have shown their interest and submitted their proposals for expression of interest for the proposals to participate in the multicentric research study. And as part of this initiative, we are having the continuing medical education program with the help of workshops and hands-on workshops at different places, different states in the country. We will be doing 12 programs in this 2 years all over the country in different states. Many states have shown a lot of interest. But I want to again come back to the concept that we want to promote, and as the preventive radiology OP. And this is one of its initiative. This is on the virtual platform that we are having this preventive radiology OP, because radiologists are not running an OP in most of the day, most of the institutions, unless they have a interventional radiology OPD. But diagnostic radiology OPDs are very, very rare. But preventive radiology, as I've already mentioned, it necessitates the need to open a radiology OPD in every institution. If it is not possible, we have to have a virtual OPD that will answer, that will make people approach us. Approach the radiologist, because we are dealing with asymptomatic patients. We are dealing with risk groups for further stratification of their risk. So we have to give information. We have to give approach to them through the digital media, and that is how we wish to work out on this particular project. I just want to know, as a leading practitioner from Trivandrum who has experience in all the three modalities and is in a teaching institution too. But Dr. Manoj, what are your thoughts on developing a preventive radiology OPD in your institute?
Yeah, that is actually, I just wanted to tell about that. We have several rooms sort of in radiology, and the current practice is that these rooms are most of the time occupied by pre-appointments, and some of the rooms are for the inpatients. That is also by appointment. That's how this thing runs. I mean, even in our imaging centers, as we know, most of the patients are coming by appointment, and maybe some percentage walk through. But anyway, uh, if we reserve one room or a time for this implementation of these schemes in any of these places, so that will become a running scheme. Say, if you have in the hospital 5 rooms, you have 5 machines in ultrasound, set apart one room, one machine, and a particular time, say from morning 2 hours, implement a particular set of this preventive radio. I mean, we are mainly now concerned with the ultrasound elastography or liver, but other things are also there. Like I have been working on these chronic renal disease.
Yeah.
In fact, that is another area of interest because so many people will have the shock of their life when suddenly realize that the kidney has totally gone. Oh, right. That is another thing. I mean, I'm just putting it, but such kind of measures are a need of our times because people do not realize when you, as we say, these are all silent, and they will not realize till the disease has progressed to such an extent that it breaks through. I mean,
Yeah.
it comes
Right.
out as a vicious thing, and I didn't knew that I had this thing. I didn't knew that. So that is something that we as a group we can, if we can put, okay, there is on room, there is on time where such things happen. I mean, we have a element of this preventive.
So you mean to
Yes,
say that preventive radiology OP for a fatty liver can something that can be at a specific day, specific this thing you can have started in your
yeah,
institution
not very specific day. I'm saying that every day
every
at
day?
a particular time,
Fine.
this will be running. So that
Yeah.
is the concept
So
that
I want to know
trying to.
how this can be practically implemented. When you suggest talk to the management or talk to the within the department, how we can do that. So there is a need for people because these are asymptomatic patients who are not going to see the physicians or this thing, but they know they have got a risk and they want to know they want to get subjected for this test to know their further risk, and may require further referrals also to the concerned clinicians like a gastroenterologist, hepatologist also. But they have to approach the radiologist now, because we are doing a program for risk stratification with the help of the imaging radiology modalities, and you are going to take history with them, see for their clinical risk parameters, get their all whatever tests they have already done, including the biochemical tests they have done. We are going for a multi-parametric assessment, or we are going for we are going to use our imaging modalities or radiological modalities for grading of fatty liver as well as for liver fibrosis assessment. So it is time for us to start this kind of preventive radiology OPD for fatty liver. And one another area that is essentially that preventive radiology is looking into is chronic kidney disease, early imaging biomarkers of chronic kidney disease, which we can pick up and inform them, and then it can be modified in such a way that the progression can be delayed. There are further workup or at least the awareness for this particular person at an early stage that can help him to prevent the further progression of or delay it into a. All these possibilities do exist, but for that,
Well,
we radiologists we radiologists have to be on the front face of approach for this kind of people, this kind of category of people. We have to be approachable, we have to be accessible. So radiology OP is the only answer for that. Either you can do it as an online or radiology OPD or a physical OPD within the radiology department.
there is one aspect or one emerging other field that is actually going to help us. I think artificial intelligence that will actually help us in many ways. One of the things is to get our patients. See, as we are discussing, how to get these patients. See, every hospital has got the records of the patients, and if we are having programs running through these records, picking out these specific uh, terms, that will bring us the patients. Because if not
Yes.
by artificial
I
intelligence,
think
actually we
Manoj
had
is opening a new this thing that on artificial intelligence integrated into preventive radiology will open up new possibilities. And Manoj was already one person who is working on apps and has developed apps to for these kind of things. And I think Praveen, we are running short of time, and I think this is a topic that needs further deliberation with another session. Praveen,
yes,
for your final remarks.
Well, I think we had a good discussion and a lot of points that have come up, and uh, thanks to both of you for sharing your experience and wisdom with the viewers. And we'll continue to have these conversations with different experts in different fields and different imaging modalities and on different aspects of the preventive radiology program and the preventive radiology OPD, as well as bringing back Dr. Manoj to further pick his brains on his experience, on his vast clinical as well as research experience. So this is a ongoing series that will continue regularly, bringing in different aspects of how radiology can integrate or must integrate, not just as a supplementary complementary modality, but as a frontline modality that can help to triage people into other medical disciplines for further care. Or to say that, well, at this particular stage, you just need stability and stabilization and more of a lifestyle change and things like that, and you don't need to get too worried at this, but come back at this particular point for follow-up and things like that. So it can play that role. And whichever way you look at it, it's always easier or more pleasant to have a pen-like object which rolls around on your body in a painless manner, as opposed to a syringe and needle poking somewhere in your body, maybe one time or multiple times, and taking out that red color fluid that we often call as blood in different volumes, and then waiting for the report. So this is an easier, more pleasant, non-invasive modality that can be looked at. So with that, let me conclude today's session. Thanks again to both of you for sharing your experience, and we hope to see you again. Goodbye.
Goodbye. Goodbye. Thank you.
thank you,
I
thank
think we
you,
have exceeded more than 1 hour.
thank you.
Thank you, Praveen.